Well, I started out wanting to be a general surgeon, but during my training, I found that I liked neurosurgery. But further on, one day I took a rotation on ophthalmology, and I just absolutely loved it. I loved the precision, the eyeball under the microscope, and the fact that the surgery was done under a microscope. Plus, I had a grandmother who was blind, and I've always had a fascination with vision. So all that added up together. I was actually a helicopter pilot in my earlier years, and then I went to medical school, and then I went back in the Army, where I did my residency in ophthalmology and then practiced for a few years. After that, I was in the Air Force or the Guard, South Carolina Air National Guard, for about 15 years. So I've been around the military quite a bit. So I actually like it. The essence is we want to laser on what we call the stroma, or the main corneal structure. On the surface of that is a skin called the epithelium, about 5 cell layers thick. We cannot laser through that. We can only laser on the corneal, on the collagen, the protein that the cornea is made out of. So one way or another, we have to remove the cells from the surface. So the difference between PRK and LASIK comes down to how we get rid of those cells. Now, PRK, which was the original procedure, we remove the cells directly, either with alcohol, or we scrape them off, or we use what we use here, which is called an Amoyal's brush, which is a soft brush that just takes the cells off and does a very beautiful job doing it without damaging the underlying surface. The other technique, LASIK, we use a keratome, or in this case a laser, to make a flap, very thin, about 150, 160 microns thick, and we pull that back, do the laser on that exposed bed, and then put the flap back. So the difference in terms of the patient is LASIK with the flap heals overnight. Literally, we have them go home, go to sleep, and the next morning they come in, their vision's great, the eye doesn't hurt, they're healed, they're done. PRK, on the other hand, those cells that we've removed have to grow back, and that's a slow process. It takes about 48 hours for them to grow back. After they grow back, then they have to get established, and they have to form their adhesions to the cornea. They have to divide and get thicker, and that takes several weeks. So healing after PRK is two-phased. First, get the cells to heal, because without those cells healed, the eye is subject to pain. So we want to get them through that. And then they have to thicken up so they have the right surface texture, the right surface shape for their best vision. So that's the difference. The difference is LASIK overnight healing, ready to go. PRK, several days to heal, and then several weeks to get your best vision. So PRK is a longer process of healing. I mean, that's the main issue. Now, what do you get for that? Well, with PRK, you don't have a flap. There's almost no complications. And later on, if you get hit in the eye or something bumps your eye or whatever, there's no flap to loosen up. LASIK is good because it's quick, but you have a flap, and there are some potential complications both in making the flap and the flap healing, and then long-term like trauma and things like that. Now, with the laser that we use to make the flap, it's much better than it was even 10 years ago. It tends to stay on the eye better. It tends to really be a really good, solid procedure. Now it's approved for the active duty, for people that are in combat, people that are exposed to, dust and wind and who knows what. But if someone asks me what is the safest, as Troop did today, is a guy applying to flight school, he said, what's the safest thing I could have? And I said, marginally, it's PRK. If it was me, what I would have PRK. But in the civilian world, where people, they have to get back to work, their lives are moving pretty fast, they overwhelmingly choose LASIK. 90% LASIK right now, as opposed to PRK. Among people who could choose. Some people we have to do PRK because of the thickness of their cornea and other things. But among people who could choose, 90% in the civilian world choose LASIK because of the rapid healing. So, it's all a matter of circumstance. Guys in the military, their eyes are really important. Are important to everybody, but I mean, because they run the risk of trauma, I think PRK still makes a little more sense for them. So we have very strict criteria today. The main issue, there are several main issues. One is pre-existing disease. For instance, people with autoimmune diseases. It could be anything from lupus, rheumatoid arthritis. I mean, the list is long. Fortunately, these are young people here in the service. We don't see that too much. We do see some, but not very much. They tend to get dry eyes. And one of the problems with especially LASIK is you can have dry eyes. So dry eyes, autoimmune disease, that is something that we don't want to see. People with diabetes we don't want to do because they have poor healing. The epithelium on the surface doesn't heal very well. Beyond that, there's not too many other problems we worry about in terms of coexisting disease. As far as the eye itself, that's the other main thing we look at. Since we're operating on the cornea, and since we're taking tissue away from the cornea, the issue is how much tissue do we need to leave untouched so the cornea doesn't warp or change its shape? Because the whole essence of LASIK is to change the shape of the cornea so it will put the image of its focusing on the retina. So anything that will distort the cornea after surgery or in the future would be a negative thing. And we found that there is a lot of people, a surprising number, who have a condition, we call it ectasia. The word really means thinning of the cornea. And it might be thinning not uniformly, but just in certain areas of the cornea. So we have a test now, a very sophisticated test, that actually is able to measure every area of the cornea in terms of its thickness. And we compare that against what we call an ideal sphere, and that way we can see if the cornea is getting thin in certain areas, or just get a very detailed look at the cornea. This test, whenever anybody comes in to see me, they'll see that I look at a whole bunch of sheets of paper that have circles with colors and numbers, thousands of numbers. Well, that's that test. And we interpret all that data, and we come up with either, yeah, you got some thinning, or no, your eye is fine. 90% of the time the eye is fine, but we do not want to do surgery on somebody whose eye might get weakened by the surgery. So that's a very critical part of the evaluation. Beyond that, it's a matter of also how nearsighted are you. The laser will only treat up to a certain level. Also, we look at the thickness of the cornea, and remember, we're taking tissue away. That's all the laser can do. All we can do it's like sanding something off. We're going to change the shape by taking tissue away from it. So we have to have a certain amount of tissue left to maintain that strength and structure. So the thickness of the cornea against the amount of correction. For instance, someone who has a -8, that's pretty high. Well, for -8, we're going to take about 160 microns off the cornea. Now, if your cornea is only 400 microns thick or let's say 400 microns thick to begin with, well, we're getting down to 250 or so, way below the limit. So we can't do certain eyes based on the amount of correction against the thickness of the cornea. It also goes to LASIK, because with LASIK, we're going to make a flap that's 160 microns thick. Well, we've taken away a whole lot of tissue, and then we're going to do the LASIK. So that really limits how much we can do. So we can't do LASIK on everybody that comes through the door by any means. People who are trying to squeeze their eyes and they're looking around don't get a good treatment. So we have to control that. We can't control it directly by like anesthetizing their eye or that sort of thing. We have to control that anxiety about their eyes. And we do that, number one, by giving 5 milligrams of Valium. Now, that doesn't sedate them. It just sort of takes the edge off their anxiety. It won't reduce the anxiety a lot, but it takes the jagged edge off of it. Secondly, we talk to them. I'm constantly talking to them, trying to get them to relax. But the other thing is that most of these guys, and I really, it's one thing I like about working on military people, they've already made their decision. They're going to do this. So they say, okay, this will pass, and they just do it, which is, in the civilian world, a lot of the people are just so, they really recoil from it. But the military guys, they just come in and do it. They've made up their decision, and now we're going to do it. So that's actually makes my job a lot easier. But along the way, we also put a device in their lids that forces it open. And I tell people, don't squeeze against this. Just let it be open. Don't squeeze your other eye. Just relax. And then the other thing is they have to look. We have a little green blinking target for them to look at. And that gives them something to focus on. And that's very important because while we're doing the actual laser treatment, If their eye can stay very still, they're going to get a great treatment because it's designed, predicated on the idea that the eye is going to be still while we're doing this very, very specific treatment. So that's why I talk to people. I get them to just look at the light. We don't want to take too long. We don't want to get people, bored with it. But we don't want to give them too much Valium either, because then they might get really like almost sleepy and not be able to focus on the light. So they need to be alert enough to have that edge to be looking at the light, but yet not so edgy that they're afraid of the light or that they just can't control their eye movement. So it's a very subtle balance of forces, you might say. So that's how it works.